15 minutes.
15 minutes. You have 15 minutes. You have 15 minutes for your presentation.
Thank you, Madam. Dear colleagues, good morning to everybody. First of all, I thank the NCD unit of the Ministry of Health for inviting me to do this presentation. And the topic of my presentation today is understanding the human-animal association, exploring the unique bond between human and animals and its role in preventing animal-related incidents, including bites. Although it's a bit long topic, I think since this whole symposium is focused on injury prevention, so I'm going to talk about how we are going to use this animal-human association and the bond between animals and human association to prevent animal-related injuries. So this is the outline of my presentation. I'm going to talk about the human-animal association, human-animal bond, and different kind of human-animal associations and negative relationships between human and animals and prevention of animal-related incidents occurring due to negative relationships. To start with, to understand the human-animal association, first, shall we see the definition of human-animal relationship? So, as I explore on this topic, so what I understood was, it was the most relevant definition or explanation I found was to a human-animal association was any manner of relationship or behavior between humans and animals. So I don't think it's so simple as that in the real world, because there are many ways and categories. This relationship can vary widely. It can be a positive relationship, negative, or even neutral. Or it can be individual, like you and your pet. It's an individual relationship. Or community, like a cultural event, like Asala Perahara, elephants participating, different kind of animals participate. It's a community event. And it may be a social relationship. In social context, we can explain it as a human-animal conflict, mainly the human-elephant conflict in Sri Lanka. That's a social relationship. So also it can be emotional, psychological, or physical. Also, it can be situational and conditional. In the human and animal association, there are different groups of animals associated with human. Because human is one kind, and there are many kinds of animals. But as a vet, I know it is very easy to handle this different kind of animals than one kind of human. So out of the topic, but there are different groups of animals. The most common one is the companion animals to us in these days. So we are all familiar with this group. Almost everyone has a companion animal. And there are utility or farm animals. That's another group. And there are wild animals. So we have to interact or have relationships with each and every group of animals. And coming to the human-animal bond. Okay. Coming to the human-animal bond, I selected the American Veterinary Medical Association's definition on human-animal bond. It explained the human-animal bond as a mutually beneficial and dynamic relationship between people and other animals that is influenced by behaviors that are essential to the health and the well-being of both. This includes, but not limited to, emotional, psychological, and physical interactions of people, other animals, and their environment. Not only people and animal, it includes their environment also. So if we explore a little onto the history of human-animal bond, we all know this human-animal relationship is as old as ages, many thousand years. According to the historians also, this human-animal association is ancient. There are archaeological evidences proving that the human-animal association is as old as many thousand years. It says the first archaeological evidences are around 15,000 years old. In Germany, they have found remnants of dogs buried between two humans. And also in Borneo, they are in their cave warts, buffaloes or cattle-like creatures have been presented in their cave warts. And they believe this human-animal bond has evolved for more than 15,000 years. And this has begun as a working relationship, and it has changed over the time. So as we all know, the human civilization was began as a hunter-gatherer society dominated by human, and this hunter-gatherer society has created opportunities for human interactions with the animals in their environment. And it believes that it was more human-centered, and the animals were used for their food or services. From this era, while the coexistence goes throughout the time, the relationship has changed. This throughout the coexistence, the relationship between humans and animals have become closer, and it has come to from the service and food-oriented relationship. It has become the relationship has led to animal domestication, and the role has shifted to agriculture animals, and then from there to companion animals. So earliest evidence show 12,000 the human and dog relationship is as old as 12,000 years. Human and farm animal connection is old as 10,000 years, and human feline relationship is old as 9,500 years. So when we are going to talk about the prevention of animal injuries, so we have to know the relationship to use that relationship to prevent injuries. So the first of all, we have to say quality of the human-animal interaction. As in any other relationship, quality of the relationship has an influence on the outcome. So in human-animal relationships, the quality of human-animal interactions can have a deep effect on the animal psychology and behavior. And it will determine the influence on animals' physiology and behavior is desirable or not, depending on the quality the behavior and the psychology of animal can change. So according to the quality, that means the interaction may be neutral, positive, or negative. When we consider the positive outcomes or positive relationships, it's always beneficial for both parties. So I told you earlier that with this human-animal coexistence, the relationship changed over the time. And the relationship between humans and animal increased. So this increased bond has created some problems also. It has good parts and bad parts as well. So with this increased bonding, animals started identifying familiar and between familiars and unfamiliars. And this recognition of familiar and unfamiliar has created a situation that they will sometimes act negatively for the unfamiliar ones. Sometimes these bites and animal-related incidents are related to these negative relationships. And it can lead to conflicts. And for dogs also, it can cause separation anxiety, not for dogs, for human as for both parties. Separation anxiety can cause negative effects on both parties. So this situation creates conflicting situations and behaviors such as bites and other animal-related injuries. So when we consider animal-related injuries, it includes bites, sting, crush, cracks, tramp. This is from large, mainly from large animals, tramp, buck off, fall on, peck from avians, and scratches from all kinds of animals. So around the world, currently, animal attacks on people has become a huge medico-social problem. I think everybody can understand this. The whole symposium focused on that. It shows the gravity of the problem. So apart from this medico-social problem, it has created a major public health problem also. And it contributes to a high level of morbidity and mortality. And these animal-related incidences, or not only injuries, it can lead to zoonotic disease, transmission of zoonotic diseases from animals to human, such as rabies, which is deadly. So most common animal to cause injuries for human as recognized as the domestic dog. And the most occurring animal incident is the dog bite. And in farm animals, it includes falls, kicks, and being pierced or pushed by horns. And there is another aspect, conflicts between human and wild animals.
Dr. Desika, you have one
Thank you.
left.
So human-wild animal interactions has occurred due to the with the expansion of human population, we have penetrated into their habitats, and it has caused negative effects on the relationship. So, when we consider prevention of animal-related injuries, the most important points are understand the basic animal behaviors in relation to their interactions with people, appreciate their flight zones, not only our comfort zone, we have to understand about their comfort zone also, and understand how to communicate with them, and use appropriate resistant techniques. Use resistant equipments as appropriate. So as I mentioned, dog bites are the most recording animal related injury, and dog bite poses a serious health risk to communities in the society. In Sri Lanka, it has recorded annually 300,000 animal bites are recorded to the hospital, and there are many incidences not recorded. And it can range from a simple scratch or bite requiring debridement and simple wound management up to serious surgeries. And dog bite poses a public health problem also because of the street dogs or free roaming dogs. Any dog can bite. Any dog can, male or female, pet or otherwise, any dog can bite. But the most relevant, most important thing is most of these dog bites are preventable. So to prevent, we have to see why do these dogs bite. It's the same as I explained earlier. So we have to understand, in short, since I'm running out of time, I have ran out of time already. Excuse me, madam, I request you 2 more minutes to finish this. So we have to, the whole art of preventing animal bite is to understand their behavior, because we think we can understand more than them. So it's our duty to understand their behavior. So and steps to prevent dog bites, I have listed as: educate yourself and your children, provide adequate supervision for children, especially when they are with animals. Socialize your animal if you have one. This will save a lot of problems. Remove your dogs from exciting situations, recognizing risky situations, and reading the dog's body language. Regarding large animal incidences, in farms, you can educate the farm workers. You can modify techniques of restraining and plan the safety of workers and the other people. So that is all about the presentation. I think I have put some light onto this topic.
Yes, Dr. Devika has elaborated how the human-animal bond is there and how it associates with individually and socially. So we'll give her appreciation. Thank you very much, Dr. Devika. We'll have a common discussion after all 3 presentations. Thank you. So the next presenter will be introduced by Dr. Irandan.
Yes, now it was highlighted about the animal bites and the dog bites. And with that information in mind, we are going to our next talk, which is zoonotic diseases and bites, exploring the link between animal bites and zoonotic diseases, emphasizing the importance of early detection, treatment, and preventative measures. The talk is delivered by Dr. Rohitha Muthugola, Consultant Medical Virologist, Department of Rabies and Vaccine QC, Medical Research Institute, Colombo. And Dr. Rohitha Muthugola obtained his MBBS from Faculty of Medicine, University of Kelaniya in year 2005. He completed his MD Medical Virology in 2013 and completed his overseas training in Japan. He's currently working at as a consultant medical virologist at Department of Rabies and Vaccine Quality Control, head of the Department of Molecular Biology, Medical Research Institute at the Ministry of Health. Dr. Muthugola represents many national level task force and technical committees as a resource person and have special research interest in arboviral infections and hantaviral infections. Dr. Muthugola, stage is yours.
Thank you very much for that kind introduction. Good morning to all. Thank you for Non-Communicable Disease Unit to organizing this present symposium as well as inviting me. So I'm going to talk about zoonotic disease and animal bites. The previous speaker has described how to prevent bites. So I will discuss what will happen after bites, how to prevent getting disease from the animals to the humans. So zoonotic diseases are infectious diseases that is transmitted from animals to humans. Disease occurs mainly due to close contact with animals. Even bites can cause zoonotic diseases. In world, actually, majority of emerging and re-emerging diseases are due to zoonotic pathogens. These diseases may be sporadic in nature or may cause outbreaks, epidemic or pandemics. I think you can remember now, just we are in post-COVID era. So COVID is originated from animals and it is zoonotic. It may become a global pandemic. Even in last couple of years, we can remember swine flu, then the MERS coronavirus, avian influenza, then Zika virus infections, so Ebola, so many epidemics and pandemics came from animal origin. So early detection of zoonotic disease are very important because these zoonotic infections, the pathogen can be adapted into the human beings and they can become human pathogen like SARS-CoV-2 came from animal, adapted to the human being, and it causes global infections. Then this is maybe due to genetic mutation of the pathogen. So it can lead to into more new diseases or severe diseases. So early identification and detection of these pathogens are very helpful to control of spread and establishing of zoonotic diseases among humans. So zoonotic diseases can occur due to animal bites as well. So maybe it's due to viruses, bacteria, fungi, or parasites. As my previous speaker discussed, more than 300,000 animal bites reported into hospitals in Sri Lanka. And around 100,000 need post-exposure prophylaxis and management for rabies. So it is a huge problem for Sri Lankan health as well as economy, as well as it's a public health problem. So viruses like rabies, herpes B virus, Batlisa virus, and many bacteria, fungi, and parasites can cause infection following bites. Then I will move on to rabies because it's a major problem in our country because 300,000 bites come into the hospital and maybe 100,000 needs post-exposure prophylaxis. So it's a major problem for our country. So we can prevent animal bites, but if it is happened, we have to prevent getting the disease. So rabies is the most important zoonotic disease in animal origin due to animal bites. It's mainly from only from mammal bites. So humans are considered as accidental host and it causes fatal encephalomyelitis. Once the disease is established, it's 100% fatal, except few bat rabies cases surviving in US. It's a bit of a thing. Because these rabies deaths are very painful, very pathetic, not compared to other encephalitis. Because in between, these patients are conscious. They know, I'm going to die. The other people are discussing, and I'm going to die. Not like other encephalitis, progressive, and you are in coma. You don't know what will happen and you will end up in death. Here, in between, the patient feel the pain and as well as the fear of death as well. So there's no cure for rabies. So therefore, prevention of the disease establishment is the very important thing, as same as the control of rabies in the community as well. So WHO estimate more than 55,000 people dies due to rabies in each year. It's a major problem in Southeast Asia, as in this map, even in Africa, in red color. So it's maybe neglected tropical disease, but is a major problem. Sometimes these patients might be the breadwinner of the family, maybe the income generator. So then the family might collapse as well. So in Sri Lanka, actually, number of human rabies cases are declining from over the years, but last 20 years, it's remained around 20 to 30. So our target is to get 0 rabies deaths in 2030. So hope we can achieve it I'm not very sure. At least we can go into single figure, less than 10. Maybe it's a big achievement. So how people get rabies? It's usually due to animal bite from any mammal, even a bat, or maybe scratch, or maybe licked by a rabid animal, mucous membranes or open wound. So incubation period is very vary. It's from maybe 1 month to 12 months. Usually it's around 3 months. Once this rabid dog bites, the virus will enter into the muscles. Then there will be multiplication in the muscles. Then it will enter into our nervous system. Once it's enter into the nervous system, we can't do anything. We have to do anything before virus enter into the nervous system. Otherwise, this virus will be transport into the central nervous system, into the brain, and produce the disease. So there's no immune response or anything can prevent after it's entering into the nervous system. So usually, I think everybody knows these clinical symptoms. It has a like a non-specific symptoms, then following high fever, then typical features like hydrophobia, aerophobia, then hallucinations, and patient go into coma and then die due to cardiac and respiratory failure. If you see a patient, maybe you will not even go into a near your pet as well, because it's like a very horrifying death. So, but thing is, disease is 100% preventable. After you get bite, if it is prompt wound care and prompt post-exposure prophylaxis will 100% prevent the death. It's a life-saving. So that is the important thing. Injury prevention, as well as if injury happens, it's going to death. So wound care is very important. It should wash immediately. Even if happens long after the exposure, maybe patient comes later without any wound care, but you have to ask them to wash it. Wash it in running water at least for 15 minutes. You can apply soap or disinfectant. It will also kill the virus, because rabies virus is not a very hardy virus. So it will destroy it by any disinfectant. So even this wound care will itself prevent the disease by 90%. So it's very important. Injury prevention may be after it's happened, injury developed into a complication and death. Then you have to go for a prompt medical care. Always after animal bite, should consult medical officer. Even the rabies treatment units are available. It should be immediate. You can't wait for following day. And you don't have to decide what you are going to do, because the medical doctor will decide what is your requirement of post-exposure prophylaxis. Please, that is the message we have to give for a public. Don't make your own decision. If animal bite happens, do the wound care, washing, and go immediately to the nearest hospital or doctor and get advice. And you have to take the animal vaccination card if it is a non-animal. And they will decide what to do. Because sometimes you think it's my own pet. We all think, no, that pet will not never get rabies, but that might be the end of the story. And also, if it is animal is killed or died, the laboratory diagnosis is encouraged. So post-exposure prophylaxis is based on the type of exposure. There may be major exposures or minor exposures, or depending on the status of the animal. Animal may be healthy and observable, maybe a stray dog, maybe it's unvaccinated one, maybe a wild one, or maybe due to bites, people might kill those animals. So depending on those things, the doctor will assess and you will recommend the post-exposure prophylaxis, so it's required or not, or they will select the regime. So vaccination status of the animal also very important in healthy observable dogs. And there's different type of rabies post-exposure prophylaxis regimes. You can give immunoglobulins and rabies vaccine, or the vaccine 2 schedules. And one thing is there's no contraindication for rabies post-exposure prophylaxis. Even you are pregnant or a small child or anyone, rabies post-exposure prophylaxis is mandatory. And the doctors and the medical care professionals should strictly adhere to the national guidelines given by the Ministry of Health regarding the management of rabies suspected dog bites or animal bites, or any problem you can ask from the expertise. At the same time, the patient should strictly follow the given vaccination course as well as the advice. If the patient is asked to observe the dog, dog should be observed. If anything happens, immediately inform into the health care provider regarding that. That is very important. So in addition to rabies post-exposure prophylaxis, the wound care we have to give if it is suturing or those things, then antibiotics if necessary, and tetanus toxoid depending on the vaccination history. And also rabies control is very important in the community and among dog population based on the responsible pet ownerships, then the vaccination of pets and keep their records, then the control of free roaming dogs. It's, I think, big public health problem at the moment. Even you go to the temple or even inside the hospitals, there may be many dogs and cats. Then the surveillance, research and development is very important to control this deadly disease, and also health education and behavioral changes of our people. Still, we see whatever do 20 to 30 deaths. Some of them never go into the hospital after dog bites. There may be some people as strict they say vaccinated the dog, then the victim has not gone into the hospital, but it's not actually vaccinated. So those kind of responsible behavior is also very important. So I think prompt wound care and post-exposure will save the life following mammal bites victims. And let's achieve the 0 human rabies deaths in 2020, I think all of us. And thank you very much.
Thank you, Dr. Mutugala. And with that, we move on to our next topic in the symposium. And the topic is moving on to enhancing responsible pet ownership and animal welfare. It's a comprehensive approach to preventing animal bites and strengthening legal frameworks. The talk is delivered by Dr. Darshani Disanayake. She's the Director of Public Health Veterinary Services. Dr. Darshani Disanayake is a distinguished public health veterinary officer with a Class 1 designation in animal production and health services. Born on August 1st, 1971 in Sri Lanka, and she is currently stands at the age of 52 and bring over 23 years of experience into her role. And she completed her graduate studies with honors at as a veterinary surgeon from University of Peradeniya. And she later pursued a master's in public health management, public management from Sri Lanka Institute of Public Management, SLIDA, graduating in 2016. As for her work experience, her extensive career spans various roles, demonstrating a commitment to public health and animal welfare. Presently, she serves as the Director, Public Health Veterinary Officer at Ministry of Health since September 2023. Prior to this, she contributed her expertise as a municipal veterinary surgeon and have done extensive work in this related subject at the Municipality Council of Moratuwa. Dr. Darshani, floor is yours.
Thank you for the kind introduction. Good morning, all. So first of all, I must thank, grateful for Dr. Samitha Siritunga for unwavering support. And I extend my gratitude, Dr. Samitha Siritunga and his team of Non-Communicable Disease Directorate for the consistent support that has paved the way for me to participate this event, making collaborative journey towards knowledge dissemination. First, I would like to, in this presentation, I'm going to highlight the issues pertaining to stray dog population. And then I'm like to talk about the responsible pet ownership, then the training and how training leads to mitigate this problem. Then I'm going to discuss the legal provisions pertaining to this issue and the current laws prevailing in Sri Lanka relating to this issue. How the law coincide with this responsible pet ownership and animal welfare. At last, I would like to talk about the community involvement and the pet licensing and pet registration. So these are the topics I'm going to cover as I discussed. So the problems of animal bites. Everybody discussed, I think the first presenter, this mentioned it as more than 300,000 bites, but I took this from the Epidunit website. It's around 200, more than 2,500 to 300,000 dog bites annually happen, and over 100,000 people receive post-exposure prophylaxis, and that is preventive treatment with anti-rabies vaccines along with the rabies immunoglobulins if indicated from the government hospitals. Next. So when we consider the stray dog population, it is around 8 lakhs. Actually, this is not only the stray dog population, the community, this includes community dogs population with the stray dog population. It's around 8 lakhs. So what is responsible pet ownership? It involves providing proper care, attention, and a safe environment for your pet. This includes regular veterinary checkups, a balanced diet, sufficient exercises, and socialization, and ensuring their overall well-being. So, key aspects of training and healthcare of pets. Training involves teaching specific behaviors and commands, fostering a positive relationship between the pets and the owner. The socialization of pets include exposure to various environments, people, and other animals to ensure they are adapt well to diverse situations. Pet healthcare involves regular veterinary checkups, vaccinations, and preventive measures to ensure their physical and mental well-being. So by doing this all, we can have a well-behaved and healthy pet. So when we consider the existing laws, these laws are very much related to animal-related laws. But for the issue-related laws, I would like to mention the Cruelty to Animals Act and Dog Registration Ordinance and the Rabies Ordinance mainly. Animals Act. It is mainly dealing with the agricultural aspects of the animal. This cruelty to animals. This is actually this is pertaining to this issue. So I would like to consider more detail in this one. It is actually 1902 and it amended lastly at 1955. It is quite outdated and not amended for more than half a century. It has negative rights. It's given negative rights to the animals in this piece of law. So it is considered to be now be repealed. It covers cruelty to animals, negligence, pain, inconvenience, breeding practices, abuse, and torture. The violation of these are the offenses, but not them clearly mentioned. Inadequate measures in penal sanctions it's like fines are like 100 rupees, which is not acceptable in modern era. So implicit way of giving animal rights. This has the implicit way of giving rights to animals in this law. This one of the other animals which is related to animals. I'm not good this one. The proposed new reforms are the status of new bill. This is called Animal Welfare Act. It is a promises of to be a comprehensive piece of legislation aligning the international standards endorsed by the OIE. First came discussion in 2005 actually. Then it was drafted 2006, but several times it came to Parliament committees, but it still under discussion. Under the 100-day program in 2015 also it came in, but this bill brought again in 2022. It got the cabinet approval, but it is not still at the state of to be enacted. It is still under discussion. So this Animal Welfare Act is considered to be as a significant milestone, and it enhances animal welfare and it aligns the international standards. It comprises separate dedicated chapters for different topics, and it covers in detail in the aspects of control of stray dog population, abundance of animals, cruelty to animals, killing pregnant animals, use of animals in researches, animal rights, improvement by introducing fines. It's more than 30,000 rupees. Establishment of an animal welfare committee for enhanced protection of animals. So all these aspects are looked in detail actually in this new law. It is in a required amount. Special provisions for separate chapters for humane treatment of animals, including handling, animal transportation, animal breeding, sale of animals, keeping pet shops. So then I'd like to discuss the other most relevant piece of laws. Those are strengthening rabies prevention activities as well as dog registration. The existing law has there are ordinances, the current rabies ordinance and dog registration ordinance. Actually, these two pieces of legislation also outdated. For example, in dog rabies ordinance act, it was mentioned all stray dogs are to be seized. But in 2006, the no killing policy, sorry about this spelling mistake, no killing policy came to action. So it's ongoing efforts to amend it for better rabies prevention act. Now they have drafted one. It happened during 2010 to 2019. It is called as Eradication of Rabies and Dog Registration Act, and it is a piece of amalgamated legislation. With these two pieces of legislation, has this current law pertaining to this is rabies ordinance and the dog registration ordinance, and it is also under discussion. For this eradication of rabies and dog registration, this is the new act. It's going to happen in the future. Provision for this eradication of rabies in Sri Lanka. It has a vaccination of provisions for vaccination of dogs, control of population, regulation of breeding for commercial purposes, and registering of dogs, and establishment of National Rabies Eradication Advisory Committee and Regional Eradication Advisory Committee. For this, has a collaborative efforts in national committee. It comprises of Ministry of Agriculture or Livestock and Ministry of Local Governments and Ministry of Health and Animal Welfare representatives. Then we'll move into this. What is community involvement? The role of community in ensuring pet safety. Community plays a crucial role in ensuring pet safety by promoting responsible pet ownership practices. Collaborative efforts such as neighborhood watch for lost pets, sharing information about local hazards, and organizing pet-friendly events. Contribute to a supportive environment. Collective awareness can be address issues like stray animal control. An emergency response plan, enhancing the overall safety and well-being of pets within the community. The importance of public awareness, when we consider this topic, it is vital as it fosters a sense of shared responsibility and management. When people are informed about local issues, community initiatives, and collaborative projects, they are more likely to actively participate. This interested awareness promotes a culture of collective responsibility and encouraging individuals to contribute to the betterment of their community through volunteering, supporting local initiatives, and fostering a sense of unity that ultimately enhance the overall well-being of the community. Why pet licensing is important? Identification, ownership. Then we can quick and reliable way to identify and reunite lost pets with their owners. Animal control officers, shelters, and veterinary clinics can easily trace the owner through this license information. Public safety, control, and regulation. Licensing pet authorities regulate the number of types of pets in the community. This control is crucial to public safety, preventing issues related to overpopulation and ensuring the animals are properly cared for. Vaccination. This ensures that pets are up to date on vaccination, reducing the risk of disease transmission among animals and protecting public health. The responsible pet ownership, spaying and neutering, microchipping, and obedience training. This encourages owners to take the necessary steps in ensuring their pets are well behaved. As a revenue source, pet licensing fees often contribute to funding local animal control services, shelters, and community programs. These funds support the care and welfare of animals, as well as efforts to address issues related to stray, abandoned pets. Community well-being, noise and nuisance control. It allows authorities to enforce regulations and respond to concerns from residents, contributing to a harmonious living environment. Last one, legal compliance, mandatory requirement, compliance with licensing regulations ensures that pet owners adhere to law, promoting a sense of responsibility of community standard. As a conclusion, to have a stricter ability for pet owners and measures to ensure responsible pet ownership, promoting public safety, I think these 4 aspects need to be considered closely. One is the legal reforms and the effective enforcement. Not only that, the institutional mechanism also very much important in this aspect. One part is from the vaccination and sterilizations, and other part is garbage disposal. Proper garbage disposal also very much important in controlling stray animal population, and awareness of the community and their engagement towards This. Those who choose to keep animals are responsible for the potential harm their animals may cause actually. So thank you very much for listening for the presentation.
Thank you, Dr. Disanayake, for giving the present status of policies and regulations in Sri Lanka pertaining to pet ownership and animal welfare. So with that, we have come to the end of this session. And now the floor is open for discussion for all three papers. If you can, you may have your questions, queries, or comments on their presentations. So you can give 1, 2, or 3 to mention to whom you are asking your question if you can't remember their names. First one is Dr. Jayasinghe. Second one is Dr. Muthugala, ne? Dr. Muthugala, and the third one is Dr. Disanayake. Yes, you can ask your questions or your comments. You can give your comments for their presentations.
Thank you, madam. I am having a small question. First one for Dr. Muthugala. If the dog is properly vaccinated, still is there an indication for post-exposure prophylaxis from that dog bite, from that dog?
It is properly vaccinated, but dog is healthy, then there's no indication for go for post-exposure prophylaxis, but you have to observe the dog. But that should be done by a trained person. So the owner can't itself decide it. That's why I asked to go for a medical advice, then those people will assess and do it.
Thank you, sir. And another question for Dr. Darshani. In these days, there are a lot of, you mentioned that there are Animal Welfare Act and the government is going to reconsider and act the new legislation regarding the dog control. What about the public, especially the that animal welfare movements and those movements' role or the impact regarding the dog control? The stray dog control especially.
Actually, they are the one who initiated this legislative reforms. And most of them are supporting for controlling animal by doing sterilization, and they're giving funds. And there is one of our doctor is from Animal Welfare Party, also can contribute some ideas regarding this problem. He is Dr. Shamit Nanayakar.
Actually, as Dr. Darshani told, in 2005, actually, we are the people actually initiated that animal welfare bill, the discussions. And actually, it's going on. We are always actually helping to the Ministry of Health because of the lack of funds, actually, Ministry can do regarding about the population control is around the 30,000 dogs, but as a welfare organization and the private veterinary organizations, we are doing the nearly 36,000 sterilization per year. And also we are doing some 200,000 rabies vaccination per year. So always the animal welfare activists actually helping because we are the people also get together and stop that killing the animals because we can actually control the population and we can prevent the rabies in a systematical manner. So the animal welfare activists and also the vets always helping to the Ministry of Health to actually do the rabies activities and make a free rabies country.
My question goes to all three members of the presenters. Now, firstly, madam, do we have any data regarding how much of this stray dog bites? I mean, the injuries caused by the stray dogs and the domestic dogs or the domestic pets. Now, do we have such kind of a data? Now, what we generally feel is that the stray dogs or the stray animals will harm us more compared to the domestic ones?
The other way around. I'm sorry, I don't have the exact data.
Can't hear.
But-
I think your mic is not on. Okay, yes.
I'm sorry, I don't have the exact data, but it's the other way around. So more injuries are happening due to domestic dogs, own dogs. So the number is less in stray dogs.
Yeah, because it will be important for the policies and the future implications if you are going to assess it. And one more question about this. Now we are talking about these interactions with the elephants, Aliminis gatuma. So do we have a sociological aspect, research about the perceptions of people who are living there? Because now, say for example, if we want to make any decisions, or let's say, policies, then of course it will be very important to have their perceptions. Because anyway, as you have correctly said, we can't change the animal, and obviously. So do we have such kind of research, or do we have any plans to do it? As a healthcare person, that is what I'm interested in. Thank you.
Actually, there are plenty of work done in this human health conflict area. So to be honest, I think during the last 3 decades, we have had 4 or 5 symposiums, international symposiums in Sri Lanka on this subject. And there are a lot of information about the aspect that you're talking about, the human-animal interaction at the level of the villages. A lot of studies has been done. Dr. Prithviraj Fernando, if you search his studies, he has published a lot of papers on this. But the question is that the problem is a very uncontrollable issue. And also like in the dog situation, like what you were raising, we have people who love animals to extreme. At the same time, we have people who hate animals to extreme. So in those areas, that is a major conflict. So what we see on the papers are some of these extreme cases, whereas this is an ongoing life scenario for them in those areas. And also one more comment to add about your question about this fully vaccination. I just want to raise this point because there are many doctors here. Fully vaccination of veterinary surgeons, we are following a protocol to vaccinate. But at the same time, now the doctors, the consultants at the hospitals, they have given a protocol from the government. They consider fully vaccinated animal as an animal who have had 2 vaccines prior to the bite, right? So that has been given to them. So we have had so many conflicts about this because, when we have a puppy, it's very difficult to get 2 vaccines prior to the bite. And then because of that, quite a lot of people get subjected to getting this anti-serum. Yeah, so that's the issue we have.
I would like to add something to that. Regarding this vaccination of animals, considering to the post-exposure treatment of human, it is 2 consecutive vaccines, 2 years apart, 1 year apart, 1 year apart. So that is because of the gravity of the disease. So they consider this strictly. That is why. So we can't assess the immunity of the dog. There may be immunity problems in dogs also. So that is why they consider this 2 consecutive vaccines. So if the dog is considered unvaccinated, if the dog has not got 2 consecutive vaccines 1 year apart. And I would like to add something to that observation of animals. In veterinary aspects, we always tell people the dog has to be observable. Although the dog is confirmed vaccinated, to delay the treatment schedule, it has to be observable, not a community dog at all. All community, any other dog other than own dog is considered unobservable. Because there may be similar dogs in the group. We can always mislead. And any behavior change or disappearance of dogs has to be called for immediate action. That's the veterinary aspect regarding the animal. That's the advice we give.
But according to his point, even though you have to be guided by a technical person. Yes. Yeah. Yeah. Yeah.
I need to add for a doctor's question. Actually, we did a little research on 2010 with Dr. Kapila Kannangara, Provincial Director Sabaragamuwa, and also with the Dr. Panditaratna. And it really says that we are taking all the hospital record, and it says more than 95% of the dog bites with our own dogs. The stray dogs are very few. That's the thing. Actually, we need to be responsible pet ownership law need to be actually amended and also need to be act immediately. Then I think the most of the problem will solve.
One,
Please, can somebody give money?
Incubation period for rabies in dogs.
Also considered it's not a thumb rule, but it is considered that 3 weeks to 3.
And in dogs,
it is also depending on there are 3 major things deciding whether the dog will get rabies or disease or not. One is the place of bite. The other one is the gravity of the bite and the viral load. Viral load entered during the bite.
3 criteria, you give 3 criteria, no? Place of the bite, minor or major, and the vaccination record. Okay, yes, yes.
and I must thank all our 3 presenters who presented here today. A few questions from Dr. Muthugala from you. One is what about now? We were told in I think 10 to 15 years back not to suture the bitten wound. What about the current situation, current status? Is it okay? What?
Yeah, current situation also same. If it is a life-saving, then you have to go for a suturing. For that, you can give ARS and wait for 4 to 6 hours and go for a suturing. If it is life-saving, otherwise you can wait a couple of days and then you can go for a suturing, especially in the face, because people are worried about their disfigurements. So you can wait, go for a plastic surgery or whatever after that.
That is after 4 to 6 hours. So
4 to 6 hours if it is life-saving.
yes.
You can keep it.
Yes.
Maybe you can maybe up to
Because
4 to 6
recently
days, depending on the surgical opinion actually.
Right. Recently I got to know about that decision, so that suturing is now recommended. Like therefore, that's why I asked that question from you. The other one is for how long the immunity remains in the body after a fully vaccination. That's I am asking a person who is bitten by a dog. Now we give ARV, and for how long that the immunity remains in the body, because sometimes people are coming to the hospital with frequent bites. Then do we need to, if that person is vaccinated with 4 ARVs doses, what about the recommendations on that?
Guideline has given the recommendation. Actually, if you have taken a full course, maybe up to 3 months, that's with available protected. But after that, your antibody levels may be exist. You may be protected, but this is 100% deadly disease. So we can't take a chance. Time we can check the antibody and give the vaccine, but the thing is antibody testing, those things are practical problems. So this is 100% deadly disease. So after 3 months of full course, then you have to go for 2 boosters, depending on your past vaccination history.
The 2 boosters means that again.
Not and day 3.
Not and day 3.
Day 3.
Yes. After that also the same.
Same thing. Because it's a
3
deadly
months.
disease.
Yes,
That's the thing.
yes.
Because we can't say
Take
at
chances,
that
yeah.
point,
Yes.
patient has the immunity or not. Maybe
Yes.
immunity is remaining.
Yes.
but we can't, without proving it,
Because
can't
now
take a chance.
this is because in the community, this is what they are thinking is, okay, I was vaccinated for my for one dog bite or animal bite, therefore I am protected at the moment, therefore I need not to be vaccinated again, like that. This is the something it's a community, they think in that way. The other one I want to it's about data. According to National Injury Surveillance, now we are conducting at the moment National Injury Surveillance. According to that one, about 12% or 12 to 15% of the hospital admissions out of 1.1 to 1.3 million total admissions due to injuries, it is due to animal bites. That is, if it is 10%, that means about 100,000 animal bites are treated as inpatients. If the total number of admissions is 1 million, that means 12 to 15% means about 150 to 200,000 animal bites are treated. And in our outpatient system, we treat about 75%, more than 75% of the outpatient treatments are for animal bites. Therefore, as you mentioned, the total number of animal bites reported to hospitals is around 250,000 to 300,000. And of that, that is our experience. As you correctly mentioned, most of the time, those bites are due to domestic dogs. Those are not stray dogs. They have those dogs have a kind of owner, but they are not residing in the houses. That is the problem. They are in the on roads, and they are and it's one cause for road traffic accidents also. Therefore, as you correctly mentioned, we need to strengthen that responsible pet ownership. That it's a very timely need. Yes, thank you very much. Thanks.
Yes. Can you please give?
I have a
mic?
small question
Okay,
regarding
okay,
this.
yes.
Dr. Muthukala, that we are working actually mass scale sterilization program in the field. So on and off, actually, our workers bitten by the dogs. So normally we are aware that it's one vaccination course is enough for the 5 years. As you mentioned now, it's give a protection for the 3 months. But if you have any possibility, because normally definitely one person bitten by the dogs for once or twice a year. So any possibility to check antibody levels, any facilities?
Medical Research Institute is conducting this antibody test. Last couple of months, we had a problem with the test, but now it's going to re-establish. So it's better for those people who are involving in the animals, continuous contact, check the antibody levels. Then you know actually your arbitrary values. Then frequent vaccination is not required then.
Actually, I was waiting to get the new test and last 2 months. And also, I think for the vaccine, association of we can propose this. We can charge them and we can services.
Definitely.
Very common problem we also have. People get
Mm. Yes, post vaccination.
I have 3 questions actually. The first one is like the Muthukala sir also knows that I was working as a medical legal officer at Kandy, and we were very unfortunate to get 2 rabies deaths during that time. And both were like, one was due to a puppy bite and other one was due to a kitten. But the puppies actually, I think somewhat can be observable. But when it comes to kittens who are kind of neglected, then we are getting frequent bites and incidents related to kittens. Is there a different kind of practice when it comes to kittens with regard to observation or the prophylaxis or the treatment plans?
Thing is, people are less concerned about kittens and the other animals compared to the dogs and puppies. Actually, if you are keeping pets for any pet, I think mammals you have to vaccinate. Even the rabbits and all kind of other things.
Yes, I mean, it's a completely awareness issue. Like recently there was this case, 4 members in the family, 3 of them died. Again, with the kitten scenario, only 1 person survived, 1 kid survived. So because when they bite everybody. And then they don't seem to care, they think that, okay, this kitten is not going to do anything. Yeah, so there are very disastrous cases like that. So it's only coming down to the awareness part.
And it's very difficult to observe kittens as well.
Yes.
The dogs, you can tie them or something and even put in a cage and see, but kittens, it's very difficult. And the next thing is in both instances, when we were trying for the mass scale vaccination in the communities, like if you can remember one from state sectors and all, then there was a problem regarding the ownership of the vaccination program, whether it should be done by the Ministry of Health or through the Department of Veterinary Sciences. So it was a kind of a very difficult thing to do. Who should do the vaccination in that particular MOH area? Because we were afraid that the disease must be spreading.
When was it?
In 2018.
18.
19, like.
Yes. Some areas there such kind of problems are there, but we have to understand. Any more questions?
Another question.
Yeah.
This is regarding this animal act, the Animal Safety Act.
Animal Welfare Act.
Animal Welfare Act. Because we are in a society who cares about almost all are like pet lovers and more into the caring of pets and all, which is also a difficult thing when it comes to controlling of the stray dogs also, because people are feeding them and all. So I'm wondering why it takes that long, because in generally people are so much kind of pet lovers and all. So why is it taking such a long time? Like, what is the real reason for that?
Actually, most of the people, those who are feeding the animals on the streets, they are also organize some kind of the sterilization program as well. Because in Sri Lanka, the problem is in Sri Lanka, 97% of the dogs own or community. Only the 3% stray. The problem is our people is not keep the dogs in their homes, not tie, not in the cage, and they don't have walls to keep the dogs inside. So the most of them have owners, but they are free roaming. That's a big problem. So then we with the responsible pet ownership law enforced in the future, we can have because I have all the details, because they have some fines about 30,000 up to 100,000. But they can't abandon the dogs, actually can't abandon the sick dogs, a lot of things here. And even when you are with a dog, you need to give a vaccination, proper vaccination as well. So then that it will be actually not solved in the future. And also the most of the people, those who are feeding the animals, they also contact us and they want to do the sterilization program. Most of the dogs in the streets, the people are feeding, they already operated and vaccinated.
Yes, if I answer to your question, why that has taken too long to pass the act? That was your question, I think. Yes, actually, in the parliament, we have been attending several meetings within last few months. From the member of parliament's side. Actually, that is also, we have to concern about that one. They are talking about agricultural animals and they are talking about predators. So predators are there. So if we stop killing predators, how the agriculture will be survived? We are an agricultural country, so we have to feed our people first. So such kind of concerns are there from other side. So that's why the discussions are still going on. Yeah. But farmers are cultivating government lands. They are doing their cultivation in reservations, forest lands. This is the scenario in Sri Lanka. So a lot of cross-cutting areas are there. Because of that, we have to think about all the sides now. In the parliament, they are talking about all the sides. So that is one concern actually. But anyhow, we should have a welfare act. Otherwise, as a country, we will be we can't face the international society, because we had an act actually, the cruelty to animals in 1902, since 1902, we had some legislation about animals. So now if we can't pass that act now, so it will be a problem for the country. Yes. Thank you.
Madam, about one thing that you didn't elaborate. Of course, we know that it's about the health that they are vaccinating. But in a forum like this, I would like to ask your inputs, like the veterinary specialist input about the current dog vaccination program that has been done. Because someone can argue that now, say for example, for measles, we have taken about 80% of the herd immunity for humans.
Yeah.
Now, one can say now, as you very correctly said, it is from the domestic animals. So then if you go on vaccinating, then you can prevent rabies. So in that case, what I'm asking is, what are your thoughts and, you know, your ideas to improve the current vaccination program in Sri Lanka?
Yes, actually, at present, we are, as the department, we are doing nothing. Yes. Because we don't have any a project or something like that. Actually, funding source is not there to do the work. As you said, actually, I think we have to do that one. But because it comes on, it's an animal disease, so we have a separate act to control animal diseases. Act is there, and also last year I attended OIE conference, also World Organization for Animal Health. So rabies was one major topic in that conference as well. So we have to, I think we can do a collaborative work with the public health officers of the medical health ministry. So doing having arguments will not give anything to the country. So we can do a collaborative work. I am ready to do that one. So we'll have a common project. And actually, we have a very good structure at the field level. 337 veterinary officers are there in all over Sri Lanka. So 1 or 2 veterinarians are heads of those officers. So to the field level vaccination program, we can collaborate with you people.
I started with giving vaccines to, it's still on the discussion actually. They agreed to take health department vaccines and do static vaccinations at their clinics in the Northwestern province. And in southern area also, they are still practicing this collaborative work regarding the vaccination.
I said it should be from the top as a policy decision. Then all the provincial directors has to take it up. Otherwise, if the particular provincial director is okay with the concept, so he will take up. Otherwise, he will refuse. So I am also not in a position to insist them. So if it is from the top level as a policy decision, I think we have to, with the health ministry, we have to come to a collaboration at the top level. Then we can, down at the field level, we can work together.
One suggestion actually now for the prevention of rabies and animal the zoonotic diseases, especially that is dog, the prevention of dog, that diseases transmitted through dog bites.
Yeah.
And especially what we first need to do is to prevent the bite, because vaccination prevents only the consequences of the bite, that's rabies and so on. Therefore, we first have to look at the prevention of bite, and also then after that, if something happens, then yes, secondary prevention should be there. Therefore, actually we started as the National Injury Prevention Program, the NCD unit, we started some discussions with draft not all, with all the stakeholders, with our health, within the health ministry, with our public health veterinary services. We initiated some discussion with them to develop national, because animal that all these acts, because there are so many stakeholders are there. Now the rabies act, the main the responsible authority is the local government.
Municipalities.
Yes. And public, that's public administration, local government, provincial councils. That is the main responsible authority. Therefore, we want to get together, and therefore that's why we started. I think we can now. This is a very good forum for us to get together and to share our thoughts and to develop our relationships and to move on to that national animal bite prevention, because we believe that prevention of animal bites will prevent the consequences like development of the rabies and so on. And post exposure should be there, and that's good. Thank you very much.
Thank you.
That's all. Okay, then yes, I want to thank the organizers for inviting me for this forum. Actually, this made aware myself as well, because as a policymaker, the policies and legislation should be very strong. As a policymaker, I have to contribute to the policies and legislations in a significant way, because as you said, we are in a green side, I think, in rabies control. So the animal bites are mainly from, somebody said 90% of the animal bites are from own dogs, not stray dogs. So we are in a green side. So we can prevent it. If the ownership is there, if the legislation is in place, if we are pursuing that one, we are monitoring, we have good monitoring program, we can prevent the bites. If it is ownership bites, 90%. So we are fully in the green side, I felt today actually. I did not, that information was not with me earlier. So after the balance, we can prevent, so it saves the government money, because we spend a lot of money on this disease, rabies. In the meantime, we have to spend money because it's a deadly disease. No, is there for rabies. So because of that, but still with your presentation, statistics and information, it seems we can prevent this one if we have a good plan, rather than dividing responsibilities, collaborating things. I think with together with the Ministry of Health, we are ready to work with you, because we want to save our people and the country. Thank you very much.
We have come to the end of the symposium. Behalf of the organizing committee, I would like to thank the co-chairs and the speakers for your in-depth knowledge sharing. And we are fortunate to have the Director General of Veterinary Department here with us as the chairperson. So we believe all the discussions we had will ended up with productive policy making and benefit all of us. So thank you very much. Let us move to the next part of the symposium, that is the presentation of tokens of appreciation. I would like to invite the chairpersons, Dr. Mrs. H.A. Kotalawala and Dr. Eranda Rajapaksha, to present the token of appreciation and the certificates for the speakers. Dr. Mrs. Deshika Jayasinghe. Dr. Rahita Mutugala. Dr. Mrs. Darshani Disanayaka. I would like to invite Dr. G.D. N. Samarutulaka, consultant community physician and the deputy director of NIHS, to present the token of appreciation to our chairpersons. Dr. Mrs. K.A.C.H.A. Kotalavala. Dr. Erantha Rajapaksha. Thank you very much. Thank you for your for the interesting session. And we would invite all of you for the morning tea, which will be served in the lobby area of this floor. Thank you. Welcome you to the free paper session 6 of the International Conference on Injury Prevalence Sri Lanka 2023. Let me introduce the chairpersons for the session. Dr. Suraj Pereira, consultant community physician, National Cancer Control Program, and Dr. Supun Vijay Singha, consultant community physician, Health Promotion Bureau. Over to you, sir.
And each presenter will give 8 minutes for the presentation and 2 minutes for the questions. So start the session. I would like to invite my co-chair, Dr. Supun, to introduce the first paper.
Thank you very much, Dr. Suraj. So welcome to the session 6 of the pre-paper sessions. So we have 5 presentations. So starting from OP number 23. The first presenter is going to present about musculoskeletal disorders, associated factors, and health-seeking behavior among small-scale handloom weavers in Kalmune Regional Director of Health Service Area. The authors are Hilmi MAM, Suravira SAIK, Pauzad ASM, and Rifas ILM. The paper will be presented by Hilmi MAM. Over to you, Hilmi.
Yes, thank you. Thank you, sir. Good morning, my dear judges and my dear colleagues. My research is on occupational health. So let me introduce the topic. It's the musculoskeletal disorders, associated factors, and health-seeking behavior among small-scale handloom weavers in Kalunai Regional Directorate of Health Service area. First, let's see what is musculoskeletal disorders. Injuries or disorders of the muscles, nerves, tendons, joints, cartilage, and spinal disc. And common it is common in physical demanding population workers. So I would say the MSD, which is caused by the overexertion. It means the repetition, forceful work, vibration, and non-ergonomical position during working. These condition causes, why it is important? Because it is associated with, it causes absenteeism, low productivity, and increase the healthcare cost. So we'll see what is the concept behind that. When they are working, the load which will cause the tissue response, that is inflammation, what we call, is the outcome. The workers might get adaptation. Otherwise, when they are doing for a long time with the repetition, they will develop the symptoms. So it might lead the impairment as well as ended up in the disability. So let's see what is a small scale. Stop moving. Excuse me. Slide is moving. Moving. All right. Sorry for the.
Yeah, continue.
Let's see what is a small scale. Small scale is the less than 50 workers are working, and the handloom weavers, they operate the looms, the machine, by manual intervention. No motors are used. The complete we can see when they are working, all 4 limbs of the body are working. During the simple attempts at a time, all 4 limbs are working, and those musculoskeletal disorders is a multifactorial condition. This is associated with the socio-demographic factors such as age, sex, marital status, educational level, BMI, physical activities, household activities, and smoking, alcohol. Like that, it is associated with small socio-demographic factors. And other thing is the work-related factors. That is static position, awkward posture, and non-ergonomic positions, and poorly designed workplace setting, and long working hours, and increased speed of working, repetitive action, like that it's associated with work-related factors. And let's see what is health-seeking behavior. That is action or inaction that is themselves, they perceive themselves to get treatment. So the justification, so why I'm selected this study, because in Sri Lanka, there are around 10,000 weavers are there. Among them, 5,000 are working in Kalmone RDHS area. Among them, 3,000 are registered in the rural industry. That is my study population. And there are lack of scientific studies in Sri Lanka. The weavers' problem is not much addressed in Sri Lanka, as well as it is a lack of priority because of the small scale, and it is not the workplaces are not in the capital of Sri Lanka. That's well away in the peripheries. And the other thing is the workers, if you consider the weavers, they are in low socio-economical status as well as they are poorly educated. That's why they are not aware about their hazards and risk of developing the occupational disease. And one more thing I have to add, because I am from that same area, I work there in the hospitals where I found a lot of patients come with musculoskeletal disorders. And I am interested in occupational health. I asked the history, and most of them are viewers. They keep it, they might end up with a developmental injection as well. That's my experience I'm sharing here. So those things make me and undertake this research priority area to fill the knowledge gap as well as use my daily practice and to make the future reference. So these are my objectives. First one is I have to assess the prevalence rate. And the second one is I have to check for the associated factors related with the musculoskeletal disorders. And to assess the health-seeking behaviors, the specific objectives are first is the prevalence, second one associated factors, and the third one is the health-seeking behaviors. Right, my study design and setting, I have done the workplace-based cross-sectional study conducted in our RDSS area, Kalmuni, and the inclusion is permanent handloom weavers, those who are registered in the rural industry, and the age less than 65 years, and they work at least for 6 months. The exclusions are they who have chronic disorders, something associated with muscular disorder like joint pain, arthritis, like that. And I exclude the who underwent any spinal surgeries and who's on long leave and pregnant mothers. So in my sample size calculation is because I have done the cluster sampling, I calculate the design effect as well as the 5% non-response rate. In addition to that, the prevalence, is there is no much studies in Sri Lanka, I got the prevalence 0.5. So altogether, I got the sample size 606. So my sampling technique is two-stage cluster sampling I have done. The handloom workplace, each workplace I considered as a cluster. In each cluster, the median number of workers is 10. So my cluster size is 10. In the first stage, I again, so the previous, this is the design. No, I have in RDS area Kalmune, there are 2 DS divisions. The division number 1, there are 135 workplaces. In division number 2, there are 13 workplaces. So according to the proportionate sampling, in first stage, I have selected from the DS area 1, 56 workplaces. So 56 clusters. And DS number 2, that is, there are 13 workplaces, 13 clusters. So I select 5 according to the proportionate sampling, simple random sampling. In the second stage, what I have done is each cluster, I selected 10 from each, that is 556 and the 50, altogether 606 samples. And these are the method. I have the Cornell questionnaire. It is done by the Dr. Jesuman, adapted by her, and I have done the pre-testing and informed consent taken. I have done this analysis in the species 26, and odds ratio and chi-square were calculated, and administrative clearance and ethical clearance was done. And this is my result. The response is 100%. This is interview-based questionnaire and administrative questionnaire. And median age of the workers is 56. Among them, 70% are male. And the prevalence is, I have calculated prevalence, self-reported prevalence. Even a single episode of pain, I consider as a musculoskeletal disorder. So where 82.3% in the last 6 months, in last work week, it was 63.9%. The common site were lower back and followed by knee and shoulder. So these results are, the associated factors are sex, age, experience, and work hours and resting hours, and mode of transport. And the healthy behavior, it was 82.3% because it is high rate, because the all are poor people, they are paying, their wages depends on their number of pieces they made. So because of that, they have to work, and to work, they have to be healthy, they seek the medical advice. So my conclusion is the prevalence rate is high, that is 82% for 6 months and 63 for last work week. So these are the associated effects I mentioned earlier, and health seeking be also satisfactory. So my recommendations are the problems, the occupational health issue should be addressed in the national level. It should be given the priority. And the ergonomic assessment in the workplace should be implemented. The intervention should be done to mitigate the MSD among the workers, among the employees. So the intersectoral collaboration must be there between the RDHs as well as in the Rural Development Authority. The technical modifications of the looms and maintenance should be done to associated with the ergonomic conditions, the mesh the worker with workplace. So that should be done. And the longitudinal study should be done to get a better description of associated factors as well as to find the temporality. So these are my references, and thank you very much.
Thank you very much, Dr. Hilmi. Interesting study area. Now the floor is open for questions. Srinika? Yeah.
Yes, yes.
This factor.
Yes.
Right? What do you mean by experience? Is it like number of years in the job, or what was?
Yeah, number of years he worked as a handloom weavers, because some people are going to abroad and like that doing other jobs. And because this normalization, the traditional working style. So what they by the tradition generation by generation they are doing. In their early younger age, they go to abroad and do something, and later of the age they are joining here. So I consider the number of working as a weaver.
Number of years working.
Yes, working as a weavers.
Right, thank you. And another small question,
Yes.
health-seeking behavior was around 80 or no, 80%.
Yes,
What
madam.
did you mean again by health-seeking behavior?
Yeah, health seeking behavior, they are seeking more than one healthcare facilities, because they are going to Ayurvedic, they are using the native treatment, and they are going to the government as well as the private
How
sectors.
did you operationalize this health-seeking behavior?
Yes, I made a questionnaire, because that is I really adapted from the previous one of my friend.
The composite score.
Yes, yes, madam.
There's a question.
I have very small clarification, but I don't know whether I'm correct or not. Now, this is a fantastic study. The pain, once if they have any pain, you have considered it.
Yes.
So could you give us little clarification on how did you classify?
Yes, madam. This is actually I have done is the self-reporting of a single pain episode. The question was, have you never been experienced pain? That's how I got the thing, because I can't assess the pain by pain score, because I am taking for the last 6 months. Another thing is last work week. So the time is limited to my study in the data collection. So that's why I just self-reporting of the pain I recorded, because they are hardworking people. If they tell pain, that is really pain. Even the pains are subjective matter. They're hardworking people. Very interesting. I must highlight here. Even as I have up to 65 years, even a single worker, single weaver has no ischemic heart disease. Up to 65 years. Someone on 1 or 2 had among the 606 sample has hypertension, but no one ischemic heart disease. How it is, those are very our areas very much high prevalence of ischemic heart disease area. But according to their working, their wages depends on their number of pieces that they have made. They're working very fast. And some other problem also there, hearing issue, tuck. Always I was very struggling to get the data collection, because the sound, the hearing issue, and the other thing is for the female workers, all the 4 limbs are working. They have some vaginal discharge as well. So those things should be studied in the future.
Okay. Thank you very much, Hilmi. One small interesting observation. Now, you mentioned the MSD prevalence was about 82%. That is
Health seeking behavior, sir?
Yeah, I know,
Yes.
not health seeking behavior, the musculoskeletal.
For last 6 month prevalence.
For the last 6 months. That is
Yes.
a very high, average.
Yes, very high.
But did you come across any other studies comparing other populations?
Yes, population in the sense I compare with the no handloom studies available in Sri Lanka. I compare in India and Bangladesh, where I found 65 to 85. There are a number of studies are there. Their prevalence 65 to 88, around 80. So those prevalence were there, so somewhat comfortable with our studies.
Right. Thank you very much, Dr. Hilmi.
Thank you, sir. Thank you very much.
I have one more question.
Yes.
So you mentioned that in Kalmune, out of handloom weavers, more than 50% are in Kalmune
Yes, yes.
RDHS area.
Yes.
So you did this study.
Yes.
So after that, were there any follow-up actions are being implemented? Because now it need to, because there are a lot of suffering is noted.
Yes, sir. Yes, sir. One thing I am interested in sharing that, because when I am doing the data collection, I referred some weavers to the hospital, because there should be I myself at that point I implement the referral system, and I advise them on all the owners who are conducting the weaving workplace. I advise them whenever, please give some time to go to the hospital and get the treatment. And I associated this study with the RDHS as well, and to the hospital. There are 4 base hospitals in Kalmune district. So I inform all the medical superintendents to make aware, that give some priorities to these people, as well as the Rural Development Authority. I got the permission. They are very friendly with us. They are very happy to have the research like this, and I share the things with them. They are also interested in making the workplace with in ergonomical aspect, to make the viewers to work friendly.
Right. Thank you very much.
Thank you, sir.
Thank you, Supun. So we move on to the papers number 2. So oral presentation 24. Knowledge of first aid for suspected spinal cord injuries among university athletes at Sabargam University, Sri Lanka. The paper will be presented by HWUS Jaisingha.
Analysis of occupational safety. Oh, yeah. Yes, yes. This should be this one. I think they can be, yeah, like this one. And they can be. Thank you very much.
Okay. Thank you very much for the panel members, and good morning to you all. So my research was based on the knowledge of first aid for suspected spinal cord injuries among university athletes in Sabargam University of Sri Lanka. Here, I mainly focused on, because in this particular topic, because in one hand I'm a lecturer, and also in other hand I'm a physiotherapist. So when we look at the background of this research, according to World Health Organization, they have identified that spinal cord injuries is another significant cause, disease which can be seen among the population. So, and not only road traffic accidents or assault injuries, but also sports-related injuries is a significant cause for spinal cord injuries. So, but at the moment, there are no reliable world prevalence estimations available, but somehow a small amount of countries were able to do some epidemiological data regarding sports-related spinal cord injuries. So according to them, as an example, if we look at the Russian level, around 30% of spinal cord injuries occur due to the sport-related injuries. So likewise, the high prevalence and sport-specific injuries observed in university sports, and it is happened due to the inadequate level of knowledge of athletes mainly. So this is my objective. It is a very simple one, to identify knowledge of first aid. It means first aid means mainly proper handling and transferring methods for suspected spinal cord injuries among university athletes in Sabargam University of Sri Lanka. So this is my methodology. It's a very simple cross-sectional survey type study, but I thought this part still didn't address by none of the researchers in Sri Lanka and university level athletes. And the study setting was Sabargam University of Sri Lanka, and the study population was randomly selected 100 university athletes. So this is my inclusion and exclusion criteria. So there I was selected, I selected first year academic, students who are in first year academic and no previous first aid training, and also completion of their secondary education without biology as a subject. If I tell you, most of the sports science undergraduates are coming from non-biological science background, mainly from economics or art likewise. Only 5% like students coming from biological stream background for this sports science degree program. So, and also I included students who engage with sports in university level and also giving consent to the to participate for this study. And in the exclusion criteria, I excluded the students who are not in their first year, because sometimes they may follow anatomy as a subject, so their knowledge might be interfere with the results. And also the students who did attend for the previous workshops related to the first aid training are excluded. And also students who completed their secondary education under the biology stream. And also students who didn't engage with university level athletics. So these are my results of the study. So around 24% actually showed the basic knowledge regarding the basic structure of spinal cord. You may wonder why they can't identify the basic structure of spinal cord, because as I told you before, most of them are not from biology background. So that might be the case. So 76% were unable to identify. It means it's a basic structure means whether it is in the posterior aspect of the body around within the vertebral column. So unfortunately, so 76% were unable to say it. And if I ask from the function, basic function of the spinal cord, fortunately, some sort of percentage, okay, around 46 were able to correctly identify the function, basic function. It means the spinal cord is helped to transfer impulses in between brain and the rest of the body likewise. But 54% were unable to describe it correctly. And also then I move into the initial course of handling in suspected spinal cord injuries. Actually considerable, if 78% were able to correctly say immobilization is the first or initial method of handling suspected spinal cord injured patient or an athlete. But again, we will move into trouble, and they were unable to identify the proper transferring technique of those suspected spinal cord injured patients. It means 82% were unable to correctly identify the proper transferring techniques. If I mention what would be the best transferring technique, so these are some of the steps. So we have to make sure that head, limbs and trunk, and including the back, and all those body parts will move as a log. So the method is known as log rolling method. So, but most of them were unable to say it, and also they didn't look at the importance of stabilizing the cervical area. So these are my some of the results. And in that interview administered questionnaire, I was asked them to freely answer what would be the causes for spinal cord injuries. Then fortunately they said the sports injuries can be taken as a cause for spinal cord injuries, but you can see transferring errors were not said by none of the most of the students. They didn't see transferring can make a significant impact on the spinal cord injuries. And also here, I asked them signs and symptoms of spinal cord injuries. What would they expect? So pain over the spine, they said weak or absence of limb movements and difficulty in walking, and also loss of bladder bubble control and sensations. But some of these signs and symptoms, as an example, breathing issues, they didn't say, because they have no idea about what would be the functions of spinal cord injuries. So this is another result what I obtained. So there is a significant association between knowledge of basic structure of a spinal cord and the knowledge of proper transferring techniques that we can use for suspected spinal cord injuries. So, and also I observed through their answers some misconceptions regarding spinal cord injuries. You can see that they might think loss of consciousness is always visible during an injury, and all spinal cord injuries are the same. They don't know there are A, B, C like categories, and complete and incomplete also. Functional recovery is impossible, some may think, and they say only affects mobility. They don't know about sensory aspect. And spinal cord injuries always involves a traumatic event. They might think like that. They have no idea about certain diseases. Sometimes degenerative diseases can cause spinal cord injuries also. And spinal cord injuries is always accompanied by severe pain. They think severe pain should be there. And spinal cord injuries recovery is rapid or complete. And all the spinal cord injuries result in paralysis also. So these are some discussion part. So previously and school level awareness regarding this handling spinal cord injured athletes were researched by Veerasekara and the team in 2016. And also there they observed the inadequate level of awareness on that particular target group. And also some of the researchers said that prior training, the actually lack of prior training on first aid among teachers and the courses in university world, which might be a factor for lack of knowledge of SCI among university athletes. So in the conclusion, I can say that this study allows us to observe there is a actually considerable amount of gap in the knowledge in of first aid in suspected spinal cord injuries among university athletes. So these are my recommendations. Actually, some of the recommendations have already implemented, and we are getting good results from that. We were able to include some mandatory course content, actually more particular modules to our new curriculum. And also we were able to conduct some workshops, and even we signed understanding of memorandums with Sri Lanka Life Saving Society as well. So we are expecting good results in the future. So these are my references, and thank you.
Thank you, Jayasinghe, for the excellent presentation, and paper is open for discussion now.
It's excluded. And do you think this 100 sample is enough to recommend all these things? Do you think the 100 sample is adequate for this?
No, actually at that moment, it was conducted in the July. So I targeted actually all the students who are in their first year, but I think we are more near to the curriculum revision at that time. So I targeted 100 because it's just a number, not particular thing. I just think personally, they can get more view. They can easy to understand if we took 100, or that easier to understand in not the scientific way, little bit. I know there's an issue with that.
Total sample, how was what is the
I
sample
think,
frame it means?
oh yes.
The entire athletics.
Yeah, entire athletic around 131. 131, yes. There are only few students who were excluded from the research.
You got only the students who are following sports science degree program.
Yes.
But when we consider athletes, any other degree programs, the
Yes.
athletes are from different faculties. So, and in your recommendation, because since it is based on your study sample, but I feel rather than recommending to include in academic program, so all athletes need to be given this kind of awareness or training program about
Yes.
first aids on
Yes, actually,
prevention and handling of sports injuries.
I agree with you,
Spinal
Dr.
cord injuries.
Yes, actually, we signed an MOU with Sri Lanka Life Saving Society. So whole Sabaragama University, not the particular department of sports sciences. So all the students from each and every faculty will be benefited from that. We thought like that. Even the research was only targeted on sports science students.
Actually, this is very interesting. As a physiotherapist, this is you have done great in your field doing this research. And one thing that I have to kept in my mind from your research, that you said only very few, like 12% of the students knew the structure of the spinal cord, just that's going inside the vertebral column. So that is very basic study, and not that because they are from the biological background, but because of the basics was not taught at the school properly.
Yes.
So when you
True.
recommend, that is one eye-opener part, and put it into your recommendation. For
Thank you very much. And also, I went through some of the curricula in UK and USA as well. They already included some part regarding spinal cord injuries in their curriculum in the school level, not in the undergraduate level. So unfortunately, here in Sri Lanka, we are not doing that. That's the
And
issue.
as a community physician, I'm fascinated by your exclusion and the inclusion criteria. Those are really nice. Thank you very much.
Thank you very much.
In the absence of further questions, we'll close this paper. Thank you very much.
Thank you very much.
Thank you, Suraj. Right, so we will move on to the third oral track, OP number 25. It's about analysis of occupational health and safety issues in Medical Supplies Division of Ministry of Health, Sri Lanka. The paper will be presented by Premadasa SNB. Over to you, Mr. Premadasa SNB.
Good morning, everybody. This is a case study about the analysis of occupational health and safety issues in Medical Supply Division, Ministry of Health. So outline of my presentation is background, objective, methods, results, and finally the conclusions and recommendations and some of the reference. The Medical Supply Division plays a crucial role in supporting healthcare facilities, ensuring the necessary tools and resources to provide the quality patient care in the country. MSD of the Ministry of Health is the central organization providing more than 13,000 items, including pharmaceuticals, surgicals, laboratory, and radioactive items. There are 17 bulk warehouses and 5 cold rooms in the MSD. And also MSD has a network of 26 regional medical supply divisions throughout the country. The key steps of drug management cycle strategically managed by the medical supply division, such as selection, estimation, ordering, procuring, storing, distributing, and prescribing, and the use of patients. 497 different categories of healthcare workers working in the medical supply divisions, and 79,738 vehicles and 160,000 people arrived at MSD in year 2021 from the RMSDs, line ministry hospitals, suppliers, and the other institutions. Therefore, the occupational health and safety within the medical supply division is important for continuous medical supply operations. The objective of this study is to analyze the occupational health and safety issues in the medical supply division, Ministry of Health. Methods, both qualitative and quantitative methods are used, and the key informant interviews with the Deputy Director General Medical Supply Division and the Director Medical Supply Division, and also the focus group discussions with the senior assistant directors, assistant director dispatch, and the pharmacists in the MSD and the OIC security services. And also inspection visit to all stores, cold rooms, and warehouses, and also the secondary data from the reviews and manuals and guidelines. And also there is some risk assessment done using the risk assessment matrix. So this is the risk assessment table used, and the consequences and the likelihood considered in this risk assessment. Some of the occupational issues, health issues and safety issues in the MSD were there were no occupational health hazard risk management, and also no hazard reporting system, and lack of monitoring and evaluation mechanism for occupational health services, and lack of management commitment to the occupational health and safety issues, and finally the lack of health and safety program for the occupational health services. These problems were further prioritized using the RVCV matrix, and finally the poor occupational health hazard risk management at MSD chosen for the further analysis by using YY diagram to find out the root causes for why this happened in the medical supply divisions. There are 4 areas were discussed: the poor use of personal protective equipments, that may be due to the unavailability and unawareness of use, and no hazard elimination or substitution. That may be due to there is no program or no plan for that. And other thing is the poor engineering control. So that may be there is no process design within the organization, and finally the poor administrative control, that may be due to the no guidelines practice within the organization. These are some of the results. And in fire and the emergency procedures and the electrical risk are the most risk areas in the medical supply divisions, and work processes, stairs, ladders, and platform, material handling stores and warehouses, and loading and unloading rocks and are medium risk, and finally the lighting, machine guards and housekeeping are and floor walls and openings are considered as a lower level of risk. So there was a higher risk of fire and electricity due to the gaps in the administrative and engineering control, awareness, and use of personal protective equipment at MSD. In conclusion, the MSD is a key institution in managing distribution all medical supplies to the healthcare institution island-wide. I think not only the public institutions, so they are supplying items to the private sector also. It was noticed that occupational hazards risk in occupational areas of medical supply division, and engage employees in the process and fostering a culture of safety are critical element in managing health and safety work environment in the medical supply division, Ministry of Health. So these are some of the recommendations to improve the occupational health in the medical supply divisions: to develop a standard operating procedures to reduce the risk of occupational hazards and outcomes, especially within the stores and dispatch areas, and introduce a 5S and Kaizen quality improvement methods, and training of MSD staff on occupational hazards and preventive strategies, and encourage the proper use of personal protective equipments like boots and heavy duty gloves and helmets and other protective equipments, and establishment of period of checkups to assess the occupational risk and outcome within the premises. And some of the long-term recommendations are: develop an institutional occupational health policy for healthcare workers in the medical supply division, and finally, appointing a safety officer to manage all kind of occupational health and risk in the organization. That is usually practiced in some of the private organizations in the country. These are my reference. Thank you very much.
Thank you, Dr. Premadasa. The paper is now open for discussion.
Structured paper, nicely presented, and it's communicated the essence of the study quite well. Just one question now. We should be thankful for selecting MSD, because most of the time our healthcare in the hospital setup, they are, at least we can assume they are safe because doctors and nurses are around. But this is a very peculiar setup that doctors are there, but they are doing mostly administrative functions. So this focus is not there in this type of peculiar institution. So I think that setting is quite good. Just one question: were there
already reported injuries that you came across in your study already reported?
So I think, unfortunately, in Sri Lankan setup, not only in the Sri Lanka, I think for healthcare workers, only worldwide, only 28 countries in the world, they have a established reporting health system for healthcare workers in the within the country. We don't have actually no such reporting system in the ministry and also within the medical supply divisions also. I think one of the study I have done to introduce the occupational health surveillance systems to the country, and I think I haven't published that one. So that include everything in how to do the occupational health surveillance system to the country.
Thank you very much. Congratulations on your paper.
Thank you, Dr. Premdas, for presentation. You mentioned that more than 13,000 items are handled by the MSD. Now, out of those, there are the so-called cancer drugs, oncologic chemotherapy drugs, as well as radioactive substances, radioactive iodine and isotopes for investigations. So those are essentially so-called hazardous. So with that, there are these material safety document, that kind of safety documents are there, and as well as those who are handling has to practice, because if I mention the radioactive substances, Atomic Energy Authority also need to monitor those things. I feel those some of the aspects may be already should be implemented, because if not, this kind of hazardous material, how can handle? So I feel you haven't come across those areas.
Yeah, because this is basically this study is based on the handling areas of the occupational. So what are the issues in these handling areas within the MSD, and these radioactive items usually they are after from the port authority, so they are directly handed over to the relevant institutions, especially to the Maharagama Cancer Hospital, like that. But there are some ways to handle these things, and there are some guidelines also. But even in that process, so there are some gaps in. I have observed there are some gaps in the handling of radioactive items also.
Thank you. I think it's very interesting and nice presentation. Just a small query. Now, you mentioned that personal protective equipment usage was low. Whether it was due to lack of implementing it, or due to lack of knowledge among the people or the persons who are using it.
I think most of them unaware that they have to use this handling this. Especially this, they are using these forklifts and everything, so they are not wearing the helmets or the whatever the heavy duty gloves and everything.
Okay, there's one more question we can take.
Actually, this was really good, and we know how you have dedicated through this field. So now you have different key informant group interviews. So how about the administrators and the people who are still working in higher level, their attitudes on this occupational hazards inside them? SD.
So that is an area of a question, because I have handed over this case study to the top officials of the medical supply division. So they agreed to implement some of the recommendations with not everything. Some of the things, especially to improve the occupational health. Even in a medical supply division, there are no this first aid box within that organizations, and no ambulance service. There, if there is emergency to transport this, even though that is close by to the national hospital, even there are no trolleys and everything. So I think those are the areas I have discussed with the director and the deputy director general of the medical supply divisions to improve the occupational health service in the medical supply divisions.
Thank you.
In the absence of any questions, thank you very much, Dr. Premadasan.
Thank
we
you.
can move on to the next one.
Thank you, Supun. We move on to the oral presentation number 26. Awareness of occupational health hazards, its preventive practices, and perceived barriers among printing workers at the Department of Government Printing Sri Lanka. Paper will be presented by Javikrama RKN. The other co-author is Ilankon IMPS.
Good morning, everyone. Imagine a world without a printed word. No documents, no newspapers, no essential documents. So now think about the individuals behind the scenes, the printing workers. So today I'm honored to share my insights on this occasion about my presentation, my research, awareness of occupational health hazards, its preventive practices, and perceived barriers among printing workers at the Department of Government Printing, Sri Lanka. So these are the contents, and for the background for my study, the printing industry in Sri Lanka in world ranks 14th by manufacturing among manufacturing industries in the world. In Sri Lanka, it is one of the key sectors that contributes directly and indirectly into the export market of Sri Lanka. But also it also contributes many job opportunities, so many job opportunities that will contribute to the country's economy. But in Sri Lanka, there are no studies have undergone regarding this about occupational health hazards among printing workers. So my study objective is to determine the awareness of occupational health hazards and its preventive practices and perceived barriers among printing workers. So moving to the methodology, this study was a descriptive cross-sectional study, and I done it at the Department of Government Printing, Sri Lanka. It is the official printer and publisher for the government of Sri Lanka. And I included both male and female workers who have a work experience of more than 6 months and also who have consented to participate in my study. And I excluded especially the workers who have engaged in job-related activities outside the selected study during my data collection period. And sample size was 422, used systematic random sampling technique. And the study instrument was a self-administered questionnaire developed by researchers based on expert guidance and literature review of a similar studies. It contains these 4 sections which address the objectives of the study. And the questionnaire was pre-tested and validated. The reliability was checked, and the ethical clearance was taken from the Faculty of Medical Sciences, University of Sri Jayawardenepura. And the collected data was analyzed using SPSS version 26, and demographic characteristics were assessed using descriptive statistic, and the chi-square test was performed to assess the association between categorical variables. And moving to the results, the workforce was predominantly identified as male and also educated up to GCA advanced level. And further, more than 50% of the workers have received information regarding occupational health hazards and safety measures when I'm doing my research. Before I do my research, when moving to this level of awareness of occupational health hazards, majority of the workers, for nearly 50% of the workers have moderate level of awareness, and only 31% got the good level of awareness regarding occupational health hazards. And this awareness was significantly associated with the work experience, years of work experience, and also working hours, as well as whether they have ever received information regarding occupational health hazards and safety measures. Then I checked their preventive practices. For that, I use how frequent these workers have implement those preventive strategies. As you all can see, most of the printing workers had never used safety equipments. They haven't used shoes, boots, or safety goggles, hearing protection equipment. Especially, they have high noise they are always exposed to the high frequency of noises, but they are not willing to use those things. And also uniforms and overall, they are well provided with those things, but they are not thinking of using those things. So there will be a question why. So then I assessed why they are not using those things. So these are the reported perceived barriers of them. They said most of them said that they feel uncomfortable while using those PPEs, and also they have heavy workload that they don't have much time to think about their protection, and also they don't have enough knowledge regarding how to use those PPEs, and also they don't have enough knowledge regarding why or the importance of using those things. What are the upcoming the risks they will face in future? And in conclusion, so the printing workers at the Department of Government Printing has moderate level of awareness, and it is significantly associated with their working hours, experience, and also whether they have received information regarding occupational health hazards and safety measures. And the practice was very poor, and most perceived barriers were feeling uncomfortable while using PPEs and heavy workload and not having adequate knowledge. So recommendation, this study highlights the need of improving the awareness of occupational health hazards and preventive practices in order to improve their preventive practices. Actually, educational programs might be an effective way in empowering workers regarding occupational health hazards and the importance of using those. So also it ensures the workers abreast of new trends and innovations in occupational safety measures and disaster management. Actually, when those educational programs should be done periodically, not at 3 years a time or so, but when recruiting, at least when recruiting the workers, we should educate those workers. So these are the references and acknowledgement. Thank you very much for listening.
Thank you. Paper is open for discussion now.
Open-ended question, and if so, what was the perceived barriers you mentioned? Maybe if you have given a place to suggestion to improve the perceived barriers, out of you gave the perceived barrier the reasons.
Most of the questions were close-ended, but I for the perceived barriers, and also I asked what are the occupational hazards they have faced. So those things I have given other section. So some of those, these are mentioned by them. Yeah.
That was the open-ended.
Yeah, that was open-ended question.
You mentioned management has provided most of the PPEs, but the issue is perceived barriers. So in your recommendations also, you need to highlight interventions to overcome these perceived barriers, because from management side, some of the interventions they have already taken.
Yeah, most of the thing, when I'm talking with them, even I got the idea that they don't think this is so much important, because most of the hazards are long-term hazards. They are rather than they are impacted in heavy loads or cut from machines. Most of that hearing problems also come in time. So they are not much aware about these things. That's what I thought, that education is much more important.
We came across, and it was beautifully presented. Thank you very much. Just that because this is also very peculiar setting, the printing corporation, and I learned through you that this sound pollution and that get something that it can exposure that can give long-term effects. Other than that, what are the risks that you sort of thought that are important to consider in this type of settings?
Yeah. In long term, they are leading to lead poisoning even. They were provided fresh milks even from the authority to prevent that. But most of them, what they do is they take that and sell it again. So they are not aware about those things. And even dust is one of the major thing in there. The paper dust and even chemical dust, and most of them use the volatile chemicals. So the printing materials, they use volatile chemicals, and they were provided with overalls and gloves, so they are not using those. Even they are very
Insight is poor.
yeah.
Congratulations on your paper. Thank you.
Now, everybody says, and also you said these personal protective environments, they are not wearing properly or not used to. So, did anybody tell about the temperature? Hari rasne hinda api me wandinne kiyala. Did anybody comment?
Yeah.
But you have not mentioned it in any perceive or any these things. So now, did you notice the temperature inside the printer, government printer corporation?
Yeah, madam. Actually, that feeling uncomfortable was under
related
that.
to that, yeah.
They were telling that it's so heatful, and also
yes, when you write the recommendations specifically, attitudes plus the temperature of a printer, that is very important as government printing, as well as all the printers around Colombo, they had very high temperatures. I saw it in a research done by the Environmental Ministry.
Thank you, madam.
This is good and very much eye-opening. Thank you so much for doing this.
Thank you.
Paper.
Thank you very much. I think we have come to the end of the session. This is the last paper, oral track 27. It's self-reported injuries and accidents among food handlers working in small-scale bakeries in Batiklo district. The paper is by Darshani K and Suravira I, and it will be presented by Dr. Darshani K.
41, right?
Over to you, Darshan.
Good afternoon, chairpersons, judges, and the audience. So my topic is today is to self-reported injuries and accidents among food handlers working in small-scale bakeries in Batiklo district. So bakery is a premises which manufactures food items using wheat or other kind of flour. It's categorized under food handling establishment according to Food Act 1980 in Sri Lanka. Small-scale bakeries are defined as employees number less than 50, and they were registered with one or more of the following. Either they should have a business registration license, trade license, or environmental protection license. Bakeries are more prone places for injury and accidents. Cuts, burns, slips and falls, and electrocutions were commonly self-reported work-related injuries reported. In a bakery, cuts can occur by sharp tools, and burns and scalds arising from hot oven, liquids. So food handler is a person who produce, distribute, store, or sell food items. So if you see the occupational accidents, any unplanned occurrences arising during the course of work, which results in injury, fatalities, or loss of production or damage to the property and assets. So slip, trips, falls, and electrocution or fire hazards inside the bakery can be categorized under this. Occupational injury is any personal injury, disease, or death resulting from an occupational accident. So justification why we did this in Batiklo district. So as you see, so Batiklo district, there is no such studies have been found so far. And the small scale bakeries were chosen because compared to large and medium scale bakeries in Batiklo district, safety measures adopted in small scale bakeries are not up to the standard according to the internally done surveys of food handling establishments by the food authorities of the RDHS office, Batik. So the objectives to describe the prevalence of self-reported occupational health injuries among food handlers in working small-scale bakeries in Batticaloa district, and also to assess the need for safety trainings among food handlers working in small-scale bakeries. So methodology, it's a descriptive cross-sectional study. Study setting is small-scale bakeries in Batticaloa district. Study population, food handlers working in small-scale bakeries. So the inclusion and inclusion criteria is food handlers working in small-scale bakeries age 18 years and above, and working in the current bakery for a minimum period of 6 months prior to the study conducted. Exclusion, food handlers diagnosed with work-related health problems prior to joining the present work, and those who were absent on the day of data collection. So sample size was calculated according to the standard formula, and the size we took was 474. And the cluster sampling method was used because we for the whole district, so 14 MOH office, so we took it as a sample, and so the response rate is 93.2. Ethical clearance was obtained from the Postgraduate Institute of Colombo, and the descriptive statistical analysis was done using SPSS version 23. So the socio-demographic characteristics, nearly the 50% of the workers were in the age category of 25 to 44 years, and majority of the food handlers were males, and out of total 477, 64.8% of them were Tamils, and the highest education level was from the category of grade 6 to O level. So the self-reported work-related injuries that were reported during the assessment period of 1st January 2019 to 30th June, the cut injury, burn injury, slips and falls, and electrocutions were self-reported during that period. And burn was reported in 73, that is 15.3% of the workers, and followed by cut injury. So the study population characteristic with self-reported work-related cut injury and burn, and both injuries were commonly reported among food handlers with the age of 25 to 44 years, who were working in processing area or baking unit, and who worked for 8 to 12 hours of work shift, and with the work experience 3 years or above. So it's very interesting because the people who had the injuries who are experienced ones. So trainings on occupational health, safety, and first aid management. None of the food handlers working in small scale bakeries had the training on occupational health and safety. And majority, that is more than 97% of them, had no training on first aid management either. And first aid box availability and its contents in the small scale bakeries. So majority of the small scale bakeries in the district did not have a first aid box. And the district, we divided the municipal site bakeries, urban and rural. So in the urban bakeries, none of the bakeries had the first aid box. So none of the bakeries which had first aid box contained the essential items or a standard first aid box should have. So they just had a box with either 1 or 2 plaster, but the standard things were not inside the first aid box. So in conclusion, work-related burn was commonly reported in injury, and food handlers lacked basic training in first aid. And there's a small correction. Majority of the workplace did not have first aid box. So we recommend training program and first aid and occupational health safety measures, and ensure all small-scale bakeries to have a satisfactory first aid box. These are my reference, and thank you.
Thank you very much, Dr. Darshini. Now, the paper is open for discussion. Yes, Srinika.
Madam, it's 50 less than workers according to the criteria. Small scale bakeries are defined as employees number less than 50.
So when sampling or like you first identified all the bakeries?
Yes, madam. In the RDHS office, you can get the FNDI unit, ENOH unit, these food handling establishments, we have all these data, so that can be collected. And out of that bakeries, we selected the small scale bakeries.
Thank you very much for your study, because we listened to researchers coming from Eastern Province. And in relation to small scale, so you categorize according to, as you mentioned previously, according to the staff number. So that means these small scale bakeries maybe the old method is firewood based
Yeah, there were some.
bakeries as well as those who are using electricity and modern oven bakeries, both are there. So your main occupation injuries, burn injuries.
Yes.
So was it common among the old method bakeries where the firewood is used as a source of food?
Yes, so actually this is one part of a study, because in this study we analyzed injury, respiratory tract problems, skin problems, and musculoskeletal problems. So now for this session, I deeply analyzed the injury part. So as you said, we had the majority, now they have changed into electricity. Those things, there are one or two with firewood also. So out of that, we analyzed the burn is the common.
Among those who are using electricity also.
Yeah, one more interesting observation I noted from your study. Now, you mentioned that people who are less than 3 years, that they have less prone to injuries. Now, could it be that the more years you spend on work, that there's a higher chance of getting burned, no other
Yeah,
types?
maybe sir, because of the place of their working. Because see the working hours and the job description. When I see the less experience, they are either putting either in the packing or serving area. So the baking. So maybe that's the reason. Yeah, yes, madam. From 1st of January 19. For the 6 months, 6 months.
Any more questions?
That's what I said. They lack knowledge, and they don't have first aid, or they don't any. I mean, the occupational or the. No, not the- Maybe. Yes.
Okay. Thank you so much, Dachini, for that excellent presentation. I think we have completed all 6 oral tracks, and I would like to thank the 6 presenters for keeping up to the time constraints. I think none of them went ahead over the time schedule. So we had 6 presentations. First one was a wonderful presentation about musculoskeletal disorders among weavers in Kalmune, and that was interesting because the prevalence was very high that was reported, and there were a lot of things in that presentation. The second one was about spinal cord injuries, which was presented from Sabaragama University, and it's among athletes, and we understood that the knowledge level is very low, as well as the transfer in the patients, that they have a lack of understanding. And the third one is about occupational health safety issues in the medical supplies division, which was a very interesting study because that was one of the settings we don't see that much of research done. As somebody mentioned, that most of the research is done in hospitals. So that was a very interesting presentation by Dr. Premadasa. And then the next one was about printing workers, so that a setting which has not been researched previously, and it actually gave a very in-depth understanding of barriers and challenges that people are facing related to preventive practices and occupational health. The last one was about food handlers, another interesting presentation by Dr. Darshani, which mentioned about self-reported injuries and the accidents. So we realized that burn injuries are the commonest ones that was reported. So all 6 percentages were quite interesting. I think we can conclude the session. I would like to thank for the presenters for their wonderful contribution, and as well as I would like to thank the judges for their interesting questions, and I would like to thank the audience for their active contribution, and then I would like to thank the organizers for inviting us, and the last but not least, my co-chair, Dr. Suraj, for sharing this session. Thank you very much.
We have come to the end of the free paper session number 6. So would like to invite Dr. Suraj Pereira, the chairperson of the session, to present the certificate of participation for the presenters. Mr. Hilmi M.A.M. U.S. Jaisingha. Dr. S.N.B. Premadasa. Miss R.K.M. Jaivikrama. Miss K. Darshani. Thank you, sir. I would like to invite Dr. Supin Vijay Singh, the chairperson of the session, to present the token of appreciation and certificates for the judges. Dr. Upuli Pereira, consultant physician of the Directorate of State and Urban Health, Ministry of Health. Dr. Srinika Velianga, Senior Lecturer, Faculty of Medicine, University of Colombo. Thank you, sir. Next, I would like to invite Dr. Arundika Senaratna, Consultant Committee Physician of the Directorate of Non-Communicable Disease, to present the token of appreciation to the chairpersons. Dr. Suraj Pereira. Dr. Supin Vijay Singh. Thank you, madam. So we have come to the conclusion of the pre-paper session. The best oral presentation will be awarded at the end of the closing ceremony, which will be held at the Grand Ballroom. I invite all of you to participate for that. Thank you very much. As a, let's take a group photograph.